Good morning. My name is Dr. Antoine Hakime. Today I'm going to perform with my fellow Dr. Tselikas. We're going to perform a complicated case of biliary drainage. It's going to be a very interesting case. And Dr. Lambros Tselikas, we're going to present you these cases.
Hello. So this is a 64 years old patient with a neuroendocrine tumor. He has already been treated with TACE, with lipoiodal TACE, and because of an increase of bilirubinemia and the bile duct dilatation on the CT scan and the ultrasound exams, we're gonna perform a first a cholangiography and then a bile duct drainage in order to be able to treat the patient again. What is important in this case is to first of all make the cholangiography, and if there is a drainage and the prosthesis being placed today, we do not have to go across the sphincter in order to avoid all the complications for future treatments. As you can see on the preoperative CT scan, there is a bile duct dilatation, mainly on the left liver, and the tumor, the neuroendocrine tumor, which has been treated, is at the posterior part of the fourth segment and the segment 1, which is, as you can see, a large tumor. We'll try to make a puncture of the left liver in order to make the cholangiography.
Because this patient has already a right hepatectomy, we're going to perform a left approach. So the best way is to be positioned at the left of the patient. And we're going to perform our puncture directly under ultrasound. First, because we want to perform a cholangiography, we're still not sure to perform a biliary drainage, we're going to use this 22 gauge needle. If I'm happy with my point of puncture, it means if I have a good orientation and if I am at the periphery of the liver, I can use directly this needle to introduce my first guide. It's a 0.18 guide. We're going to use here the V18. With this kind of guide, you can catheterize the biliary system, and then you can introduce your introducer. Here is going to be a 6 French introducer, because then after, we're going to use after a 6 French biliary catheter. We call it the BMC from Cook. As I told you, now with Dr. Ambrose, he's going to puncture under ultrasound the left liver. He's using the 22 gauge needle. Even with this 22 gauge needle, even if we don't see very well the biliary system, it's not very important. We can just go to cross them, and then we are authorized to opacify, to perform a opacification until we will see them under scopy. So now you can see the needle inside the left liver. It's a very good orientation. You have a 45-degree angle. And he's going toward the biliary tree. We assume it's one of these 2 canals just now in front of the needle. We're going to put color in the ultrasound to see which one of these 2 canals is the biliary system. Tu peux mettre la couleur, Martine? So this is a portal system. So the biliary should be just above. Je trouve que tu es assez central. Hein. Occupe bien hein, si tu veux remonter. Ouais. So with this 220 gauge needle, if you really want to redirect it, you have to withdraw. Then you can redirect it. It's a very thin needle. We assume that he's crossing here the biliary system. Maybe it's inside. Now we're going to take very diluted contrast and we're going to perform opacification while we are withdrawing the needle. So we don't have to inject very much, otherwise we won't see anything after on the screen. Now we're going to inject contrast. So now start withdraw the needle. Retire, ne concentre, ne dis, voilà. Tu le verras tout de suite. Hein. C'est toujours pas. So we didn't get any biliary opacification. So with these 220 gauge needle, it's kind of scopy and ultrasound combination to perform our puncture and approach. Right. So as you see, I get the opacification. So we're going, I'm very happy with my approach. It's a peripheral approach, good angulation. So now, this is for rich people only, sure. I'm going to use my V18 thin and strong guide wire. Putain, il fallait l'engueuler. Bon, manifestement, je crois que... Because the biliary tree was not very dilated, that's why I prefer to use directly my 22 gauge needle to put directly my guide wire. C'est tellement rare de faire des opacifications, j'ai plus le réflexe. Ouais, je pense que c'est bon. Sans perdre le guide, on sait jamais. So now we're going to complete our opacification, all the opacification to check for a stenosis. I have secure my approach, so I'm going to complete my opacification to check and to confirm the presence of a stenosis. So systematically, we take some biliary liquid for bacteriology examination. Okay. So now I have performed the opacification. You see here the left segment of the biliary tree, and you see here the main bile duct, and you can see here that there is important stenosis. exactly as we assume in the CT scan, in the center of the liver. So now you see there is important and long stenosis between the main bile duct here and my biliary, here the segment 2 and segment 3. Between these two segments there is a huge stenosis. So now we're going to try to find our way to catheterize the main bile duct and to put here a stent. As you see, we have a nice puncture point, entrance point here. So we have place between here and here, a safe segment. So we're going to be very safe after to put the stent. So now my colleague, Dr. Tselikas, he's going to try to catheterize the stenosis and to find his way until the main bile duct. And he's pretty sure he's going to do it. Ah, peut-être que tu auras besoin un peu plus de contraste. Ah, tu l'as, c'est bon, t'es rentré. Ah, je pense que tu auras besoin d'un cathé. Hein. C'est terrible ça. Moi, je l'ai vu exactement ton image. Ouais, non. Et voilà. Et là, tu montes un peu. Ouais, tu montes un peu. Voilà, voilà. Va quelque part. On va mettre. Je suis sûr qu'il faut un cathé. De toute façon, il faut passer. On n'a pas le choix. Hein. Il faut. Voilà, là, par là. Là, tu entres. C'est pas grave. Va dans le 3. Va dans le 3. On va pour mettre un cathé. Voilà, là. Pour moi, c'est par là. Ouais. Je sais pas pour toi, hein, mais il faut le cathé. Ça, c'est quoi? Vas-y, ouais, vas-y, t'as raison. T'as une petite branche, peut-être un peu sténosée. Ouais, t'as raison, c'est toi qui as raison. C'est exactement ça, on la voit, les sténosées. Hein. Well, first, we're trying first to catheterize this stenosis with only a guide wire without a catheter, because we prefer to be sure that we're going to cross before putting a bigger catheter, I mean by that a bigger hole. Because if we do a bigger hole and we don't succeed to catheterize, there is a risk of an important leakage, a peritoneal leakage. But we have to use a catheter to catheterize the stenosis. We have to use this dedicated catheter for the biliary system. We call it the BMC. It's a 6 French catheter. It's strong, and you have a small angulation here. And to use this, we have to take a bigger introducer. We have to take a 6 French introducer. But we don't have here, it's a 7 French. So we're going to use a 7 French introducer. So to perform in a safe way the exchange of introducer, we put a strong wire. Here it's a Amplatz. It's a very strong 0.35 guide wire. So we put it inside and we're going to do the exchange of introducer with this wire. Ouais, t'as raison, c'est toi qui as raison, bravo, hein, je l'avais pas vu. Putain. En artériel, tu sais, c'est tout droit. Attention quand même le guide, vas-y. Il arrive. Laisse le guide en place quand même, j'aime bien le... Tant que je suis pas sûr... Tu vois ce que je veux dire? Ouais, tout à fait. Putain, t'as le chemin. Tu l'as cathétérisé, t'es trop fort. C'est ça. So, we can see now with this bigger introducer and a nicer opacification, we can see very well the stenotic segment of the left biliary canal. Non, tu le passes au Terumo. Terumo. Ouais. Je prends pas de risque. Ouais, passe celui-là. Ouais. So now we're taking our Terumo guide, hydrophilic guide wire, to cross the stenotic portion. Jusqu'à maintenant, tout est beau. L'approche est... Je te promets, 3 personnes sur 4 auraient piqué juste en amont de la sténose et ça aurait été galère. Ça fait des fuites, ça fait tout ce que tu veux. So we have to be patient. We have to find our way. Sometimes it takes time, but here, when you see a segment, usually you're pretty sure 100% that you'll cross it. Tu mets trop de contraste, tu verras plus ton cathé. Ah oui, pour dégager, c'est ça? Ouais, tu l'as. Il part au début, c'est ça? On a l'impression un peu plus tôt, c'est ça? Hein? Ouais. Ouais. Ok, si c'est ça, on va aller un peu, on va rentrer. Incroyable. Voilà. Et voilà. Ok, ils ont vu l'image? Merci. So, it was not the difficulty here was try to find what was to find between all this opacification which one was the origin of the stenosis. So now we have catheterized the stenosis. Merci. What's very important here is not to catheterize the sphincter, because we really don't want to do a sphincterotomy, because otherwise it would be a contraindication for further treatment such as chemoembolization. So we're going just to keep our catheter above the sphincter. On est bien. Non, ça passe facile. Voilà. Le sphincter est un peu plus haut. Hein. Voilà, il est un peu plus haut encore. Now we have crossed the stenosis with the catheter. It was very easy to cross it. As I told you, when you see opacification, we saw from the beginning opacification of the main bile duct. It means that when you see it, you're pretty sure that you have to succeed to cross it. It's possible. Now we're going to use our very strong guide wire, the Amplatz. So this is a very strong wire. On le verra parce qu'on a la chance, c'est qu'on voit le sphincter n'est pas pacifié, donc avance un peu encore. Voilà, là pas plus, ouais, pas plus. Là tu retiens, ouais. Je vais te demander un truc très important, le bout de mon désilé. So we're going now to performing a very nice opacification to see exactly the length of the stenosis. So we inject in contrast. Le problème c'est qu'avec cette ouais, c'est une compression. Hein. On est très très bien. Putain, on voit pas très bien l'origine encore. Hein. Allez. On va utiliser celle-là, non? Voilà, on va... Il faut éviter la... Allez, vas-y. On la voit, ouais, la sténose. T'as raison, on voit la sténose, le plus important de la sténose. Ok, vas-y, allez. So we're going to measure the length, exactly the length of the stenosis of, and the choice of our stent. We're going to use the Guidewire. Ton guide est bien, hein, pas plus loin, attention, hein, t'as vu, il est là, voilà. Qu'on franchisse pas, le pauvre, qu'on lui fasse pas de sphinctéro. Vas-y, tu peux l'avancer, Je le vois, moi. Vas-y, avance. Fais un point fixe, donc t'avances. Voilà, stop, pas plus, voilà. Tu vois, on voit tout de suite le guide franchir. Ouais, pas plus, c'est bon. On peut le désiler assez grand pour que je te purge tout ça. Je vais tout nettoyer. Ok. So we put here. Je vais prendre un truc. Voilà. So we're going to put one of the extremity of our stent here. So we're going to put the guide here. Il est là ton guide. So and now we're going to retrieve the guide until the other extremity. You can see here. And we're going to put it until here. And now we can measure it. So we have measured 8 millimeter. So we're going to choose a stent of 8 centimeter length. Yes. C'est lequel habituellement que je mettais moi? Ok, tu vas me donner celui-là là. Hein? Ouais. Ouais. In the market, you have different stand dedicated for the biliary tree. Here we have the self-expanding stand Silver from Cook and the Illuminex from Bart. So your choice is really operator dependent, and in this case, we're going to use the Bart. So it's very easy to use this stand. First, we're going to purge it. So we purge it from here and from here. This is the security system. When you will be in place, we remove it. And then it's very easy. You just have to press on this button and the stent will open. And you'll keep pressing until it's totally fully opened. So, ouais, après une fois que tu es en place. This stent can go through our introducer. Ouais. T'as enlevé le cathé? Ouais. Ouais. Le guide est très bien. Je vais laisser un peu avancer. Vas-y. So the stent is arriving. You can see it here on the scopy. So now, no. Je pense là, comme ça, pas plus. Comme ça là. We're happy with the position. So last opacification. Non, vas-y. Ouais, on est très bien. C'est très bien, tu as le départ du truc en haut. Allez, vas-y, moi je suis bien comme ça. T'as enlevé la sécurité. Ouais. So now I released it totally. It was no problem, without any problem. Petite opacification, je pense qu'on est bien, mais... Allez, tu mets... On fait une incidence tout à l'heure. Voilà, c'est celle-là, non?
Ouais, c'est celle-là.
Vas-y. Usually we prefer to keep a drainage, external drainage, for security. But here, there is different reason why we're not going to do it. First, as you can see here, there is no blood in the introducer. We didn't perform also a dilatation, so there is no risk also of bleeding. And we want to perform chemombolization, so it's better to try to go quicker and to take any risk of infection. So I think it's better not to keep any drainage inside. So the procedure is over. We're going to retrieve everything. We're very happy with this procedure. We perform exactly what we intend to perform. We put a stent very far away in the biliary, in the main bile duct, and to avoid any kind of kinking of this stent because of the angulation between the left canal and the main bile duct. And there is as you can see at the end of the procedure, there is no any compression on the stent, so we don't need to perform any further dilatation. And we have retrieved everything, and this patient can be ready next week for chemombolization of this neuroendocrine metastasis. Thank you very much. Thank you very much, Lambros, and see you for a next case. Thank you.